Okay, now geriatric medicine. So the first question is when this is started. What is the age limit or cutoff for the geriatric population? The age limit is above 65, and now then we will discuss the why it is important, and there are some physiology is attached to it, and there are some pharmacology attached to it. So these are the some different aspects that we are going to touch upon in these presentations. Okay, geriatric medicine involves the care of elderly and usually age 65 and above. How does it differ from internal medicine or family medicine? That's a separate question. We will go on to the geriatrics and what are the differences that are there. We have discussed that there are multiple illnesses that are there, unique mode of presentation of illnesses. So they can present differently with the UTIs, with the pneumonias. Pneumonias and UTIs maybe in elder, if you are talking about an elderly population, the elderly population is not going to present like a burning maturation in UTI. They may going to present like loss of consciousness, irritability, decreased appetite, same as pediatric population. They have different presentations. It goes through also with the geriatric population. They may have different signs and symptoms, not necessarily related to the system that is involved. Multiple illnesses together make the syndrome. So if there are multiple illnesses there, then it's going to have an additive effect, and that needs to be dealt in a very aggressive way. Elderly attributes a lot of symptoms to old age and not disease, and marginal reserves. They also have very marginal reserves. So like in pediatric population, you need to be very careful because you don't have much time, because you don't have much much differences. But for elderly also, we have both marginal symptoms. So someone also said in the chat box, differing physiology with increasing age. Yes, and let me have some comments from the chat box. Yes, dosage of the drugs are different because of the functions of their origin unless, yes, so doses are also very important in this aspect. So if you see here, the elderly population, they usually have lot of comorbids. They may have diabetes, they may have hypertension, osteoarthritis, benign positional BPH, benign prostatic hyperplasia, may have cataract. But if you combine all these, all of that is going to contribute to one thing which is called here as fall. So they all are they may contribute towards fall, and we can deal fall as a separate identity. We most of the times what we do is, as healthcare professionals, we concentrate on different comorbids that are there, some medications that are there, but as a cumulative identity, they may be at risk of fall. So fall is something very significant in geriatric population, and that needs to be cared of in very carefully. Okay, so let's talk about some differences: physiological, pharmacological, even the pathology, performance functioning, their perceptions, positions, and plan. So they all have different history and history of presenting complaint. As you go in pediatric population, the birth history, childhood times, and at times family history redundant. Functional history is extremely important. So in geriatric population, which is the thing which is important is the functional history. And then collaboration with essentials at times. Detailed drug history is very important, and detailed review of symptoms is very important. System is very important because you may miss something. And exam has to focus on functional assessments and involve some special tests. What are the special tests and what is going to be the functional assessments, we will discuss later on. So let's see, it's a rapidly changing thing, increasing lifestyle. So the load is getting increased day by day for the geriatric population. And currently there are 5% of all our population is elderly. Okay, now if you go with the system by system, you see the physiology which is going on in geriatric population. There is 10% loss of neurons. There are demyelinations going on. There are delayed nerve conductions and decreased sensory input. So this is all which is going at a physiological level on in CNS. Special senses, lenses become thick, pupil size reduced, reduced depth perception, and macular degeneration. So you may expect these kind of people to have decreased vision. Same goes with the ears. They have wax become drier, there's stiffness of the ossicles, so they may listen louder sounds, and there's also going to be cochlear and central degeneration. They also have loss of taste buds, and that's the reason they have the nutrition is going to be a problem in those kind of population. If you see CVS, there is arterial stiffness, so baroreceptors is also going to be decreased, LVH function is decreased, and decreased blood flow. So there is generally cardiovascular weakness in a geriatric population. So you need to be very careful in this. If you see respiratory system, their cough reflex is going to be weak, and their chest wall is stiffness and decreased elastic recoil. So if there are, what is the problem if there is a weak cough reflex? The weak cough reflex is going to cause may cause recurrent chest infection, and if the chest infection develops, it's going to be very worse in elderly population. So you need to be you need to aggressively treat the chest infections. If you see GI, they have dental decays, decreased acid production, gut slowing which causes constipation, reduced absorption in the smallest intestine, and there is reduced liver blood flow. So there is a impairment in the GIT also. If you see musculoskeletal, there is a 30% muscle loss. There's joint degeneration, which causes osteoarthritis, increased bone resorption, and decreased bone formation. We will discuss what are the things that we see as a clinical manifestation later on. Renal, if you see here, there's a 10% decline in the creatinine clearance. So what it means is, it means that you need to give medications which may cause nephrotoxicity, lower doses, because they tend to be there in the kidneys longer. So that's the reason they need smaller amount of drugs to be effective. There is a nephron loss going on, and also the decreased blood flow. Endocrinology, decreased glucose uptake, decreased insulin release, increased parathyroid hormones, and decreased reproductive hormones. If you see skin, the elasticity is gone down, gland activities, subcutaneous fats, and nail bed functions, they all are impaired. Immune system, obviously the immune system, that's the reason we say that these are immunocompromised people, because they have decreased interleukins, antibodies are getting low, and there is a cellular immunity has very impaired response. So what physiological effects that you're going to see in a geriatric population? So if you see here, CNS, because what we are concerned about, how the patient is clinically going to present in our clinics. So minor forgetfulness, decreased sleep, numbness in the feet. Patient may have this as a normal physiological problem. If you see here, there is special senses, decreased sight, decreased hearing, smell and taste. These are all normal issues in geriatric population. CVS, if you see here, because of the physiology that we've discussed, they will have orthostatic blood pressure drop, diminished exercise capacity, rhythm changes, or you can also see some rhythm changes which are normal. Respiratory, we also discussed weaker cough reflex and mucociliary clearance is decreased. That is going to cause the recurrent infections. GI, dry mouth, loss of appetite, constipation, and vitamin deficiencies because of the malabsorption. So these are all clinical manifestations that you can see in those patients. So this is the reason for it. Minor forgetfulness because of the 10% neuronal loss. Demyelination will manifest as decreased sleep. Slow reflexes, numbness in the feet, decreased light, wax impaction, smell and taste because of the loss of taste buds. So these are all explanations why you see here the why do you see here the clinical manifestations. These are all physiology behind it. There is a widened pulse pressure. What is a pulse pressure? What is this pulse pressure?
Difference between the diastolic and systolic blood pressure.
Okay, good. So difference between the systolic and diastolic blood pressure. Yes. Okay. So it's going to be very wide in those kind of patients. Because of the baroreceptor response, they have orthostatic blood pressure drop, the rhythm changes, and liver ventricular functions is going to be decreased. For weaker cough reflex, so they have generally they have the respiratory system is very fragile. If you see here, they're going to have dry mouths, constipation because of gut slowing, vitamin deficiencies because of malabsorptions, cytochrome P450. So any drug which is cytochrome P450 inhibitors, they are going to cause troubles in those patients. Okay, now 30% muscle loss, reduced in physical activity, osteoarthritis is there, osteoporosis is there. Because of the 10% decreased creatinine clearance, so you need to be very careful while you are prescribing some medications. It's going to stay longer. Glucose intolerance problem, osteoporosis is a problem because of increased parathyroid hormones, and there are pelvic floor weaknesses also present. Dry skin, sweating, thick nails, these are all physiology behind it. You have decreased antibody responses, which causes fever and infections more frequently, and they got very complicated very easily. Now let's discuss about the pharmacology. There are also pharmacological differences. Pharmacokinetics, pharmacodynamics, blood-brain barriers, hepatic and renal functions. These are all impaired. Reduced gastric acid emptying and circulatory changes, decreased lean body mass, and increased fatty tissues. So if you see here, the excretion is going to be impaired, and there's also a reduce in the liver mass and decreased GFR. There is another thing in the geriatric population is polypharmacy. The geriatric population are getting a lot of medications, and this is why they ended up in polypharmacy, and which leads towards more adverse effects and more interactions. So you need to be very careful, carefully review these uh, these interactions. Maybe the geriatric population, they are they are in they are getting multiple drugs for the same reason. So you need to delete the drugs that they don't want and which is best for them. So how are you going to prescribe those medications? You're going to prescribe it, start low. So you need to start with very low doses and you need to go slow. Number one rule. Number second is 20% of all hospitalizations in elderly are related to drugs they use because of the increased drug, because of the drug toxicity, because of the drug interactions, maybe because of the drug adverse effects, they are going to have these problems. So ask patients to bring in meds, not just prescriptions, because you need to be, you need to make sure that and that there are that the patient is taking the right medications, because they usually remember the colors and the sizes and the shapes, so that may confuse you and the patient. So you ask them to bring all the medications with them. The second thing is all the antis you need to take very cautiously, because they're going to cause very easily side effects. Anticholinergics, convulsants, antidepressants, antihistamines, antipsychotics, and of course benzodiazepines. These are all medications you need to use it very cautiously, because they're going to cause adverse effects very easily because of their renal pathologies. Pharmacokinetic altered cell receptor response, greater CNS effects, increased nephron hepatotoxicity is going to be there. Okay. So that's about the pharmacology or the physiology attached to the geriatric population.